for giving me this great opportunity. A prayers to God. Second is, artificial intelligence does not suffer from hypoglycemia, but whereas humans are. So to stand in front of you and the lunch, it's a difficult task. Ma, the kutulak konjam paathula. Ask them to remove that. So the topic was when synapse meets silicon, a lot of things happen. And you know that the computers work on binary. Even the latest computer works on binary, whereas only yes and no. Recently, the third dimension Po, which is neither yes or not no. Yes, no, and Po. Only the three. Whereas the human computer, they term it as 19th generation quantum computing. You can imagine the kind of network which has got, which can never be matched by the sound, please. Why video is not playing? I'm sorry about that. Yes. Okay. Anyhow, to just carry home point is, this is a famous clipping Rajinikanth. You can see the AI triggers here. AI triggers the weapon, and you can see what happens there. And the AI is getting unlocked, and he says, "Can I have the sound, sir?" Anyhow, no issues. Okay. What I am trying to tell you is AI is crept into every field. Do you think AI will replace physicians? It's not going to do, but however, physicians who use AI will replace those who don't. So you have to learn to live with it. 100%, it is going to be part of your life. So better know it. Otherwise, you cannot survive. The revolution is how responsibly we can harness this technology power, preserving our essential critical thinking. That is the challenge. But unfortunately, the youngsters are totally dependent upon the search engines for answers, and even for very, very basic things, they look into the net. The generation is growing like that, giving sabbatical to the inherent intelligence. It is not the same older generation blaming the younger generation. The truth is that I find the very basic things in teaching is all. So AI is, as you said, the father of one of my previous speakers said about the McCarthy, who says science of and engineering making intelligent machines, the father of John McCarthy, in artificial intelligence. Now the AI is not rigid. It's not a predefined algorithm. It's probabilistic, self-adjusting, and capable of learning. A lot of learning networks and vast dynamic data sets, making it significantly less scripted than the traditional ones. The four basic models, there are a lot of innumerable models based on this, but the basic four things are the machine learning, the deep learning, the NLP, and the robotic process automation. The last one is most essentially fixed commands like billing, or you give a set of rules which the robotic process automation will do. Fees for the consultant, or trace, or all the entire your inventory management, all these things is by that. So these are the few terminologies you should definitely know. Is machine learning is the pattern recognition from data. Data can be small or long. Deep learning is multi-layered neural networks. This is the hub and spoke, and weightage is given to each one of the hub, and then it comes. The convolutional neural network, the CNN, is one which is spatial, whereas the recurrent neural network is temporal. So in any event, the space and the time are the two most important things, and these two networks take care of this. Why this is important is when you plan for young neurologists are now at a stage where all the AIs have come into play. It is your role is to regulate them, and you will be there now testing all this AI about their validity. Validating the AI is now in the hands of younger generation. So whenever you plan your research, you have to take space and time into account. The most important field in neurology where it is completely right now in real world application is stroke. Why in stroke is speed matters. As you know, time is brain. Every minute delay, 1.9 million neurons lost. AI enables real-time triage and very fast decision making. You know, AI Rapid, which is one of the leading software in most of the angio suits, gives you the diagnosis in 3 minutes, saving about billions of neurons. Waiting for the radiologist to report all this, nothing. It all gives in. And second is accuracy and consistency, fairly well tried across many countries. It overcomes the human limitations, as I tell, fatigue, hypoglycemia, distraction, inexperience, and everything. And AI also provides a second set of expert. Once AI flags some decision, you can always look into those areas where you can reconfirm that also. And supports non-specialist centers in rural hospitals. So the reporting is possible. As you know, that cardiologists were far ahead. They have created a AI algorithm for ECG for long back ago, and then it is already in the real world. Better outcomes, the door-to-door needle or groin time is grossly reduced. I'll show you a few of them. Now it is there in everywhere. The classification of intracerebral hemorrhage, volumes of the intracerebral hemorrhage, aspect score, whether large vessel occlusion is present or not, or CT perfusion measurement, or collaterals are sufficiently present, or mismatch calculation, whether I should thrombolize or should not. Everything you have got AI now. The 4 C's in the intracerebral hemorrhage: clot, compression, cause, and the complications. All the 4 aspects now the AI is able to take care. And the deep learning algorithm in ICH detection, this is the one based on a very small data set it can identify. Sometimes the hyperdensity is not visible, but whereas this analyzes pixel by 6 pixel and tells where the hyperdensity is there. Very, very important in hematoma expansion. If you really look at I'll show you the next one. If you see the hematoma expansions, the volumes are slowly increasing. So repetitive scans would tell you whether hematoma expansion is there, neurosurgical interventions needed or not. So these things are now well taken care by things. And the other 4 P's in acute ischemic stroke are the parenchyma, pipes, perfusion, and the penumbra. This is completely taken care by AI nowadays. I'm showing you this is a area where you can see the infarcted area, and that is this is the aspect score, area of suspected low attenuation. Sulcal effacement are shown in transparent red overlay. The anatomical aspects region which are normal are shown in green. The aspects which are identified as infarct outlined in red. The aspect score it is given. So aspect score is the one which decides whether you're going to thrombolize or not. And second important thing is the aspects, anterior circulation aspect is there, posterior circulation aspect is there. All are now available. This is a quite interesting study where automated large vessel occlusion detection by software and thrombectomy is a JAMA article. You will see the conclusion, the findings first line. Use of AI in this has statistically significantly reduced the door to groin time. So almost millions of neurons have been saved by this. You will see the average time is from 91 minutes in the routine non-AI and 60 minutes. So the door to groin time is grossly reduced by the AI. So this is where the collateral scoring is also there, and all the parameters, name everything, the regional cerebral blood volume, regional cerebral blood flow, mean transit time, Tmax, everything is calculated by AI nowadays, and you give the entire city. It also does the denoising of the images, does super resolution of these images, and a 3-minute ultra-fast MRA protocol for screening acute ischemic stroke is presently available, which also gives to the collaterals. So prediction of, not only that, it can also predict. See, for example, if a subtle hemorrhagic transformation in the penumbra, you will not be able to, not be visible to a naked eye. This AA will picks up that based on the alteration in the hyperintensity in the MRI. So predicting stroke outcome also is done by multimodal. So you have, see here I just want to tell you one. There are, what they do is they take, there's one very interesting study on post-stroke cognitive impairment. They have taken about 118 parameters. They have given weightage to each. For example, demographic parameters or imaging parameters or risk parameters, blood data, everything. All the 118 parameters with different values and all, until predict whether the patient is going to develop a vascular dementia or not. So taking into account about 200 parameters, giving a weightage for each one of the parameters, taking all into account and making a decision. Our brain does it, but the AA does it significantly better. The studies have proven that, and this is also published in the Journal of Stroke. This is the functional outcome prediction in LVO, large vessel undergoing mechanical thrombectomy, and combining artificial intelligence assisted image segmentation and ultrasound based radiomics for prediction of carotid plaque stability, where you combine the AA with image segmentation, combine both imaging and the clinical features to identify whether the plaque is stable or not. So what usually previously neurologists used to debate whether CT is faster or MRI is more sensitive. Now the real debate is AA has flagged it. Shall I go ahead or shall I wait for the radiologist? So, but you should remember, AA can recognize patterns, but only neurologists recognizes the person behind them. Empathy makes treatment truly individualized. So the Whiz AA, which detects LVO detection, aspect scoring, mobile alerts, Rapid AA, CT perfusion maps, mismatch calculation aspects, automation. IDOC is ICH identification triad support. SINA is a AA which is CTA based aspects and LVO. The impact is faster decisions and treatment, more consistent stroke diagnosis, improved interdisciplinary coordination. Most important thing is, don't think that is always there for AA also hallucinates. You will say, sometimes when you search for a data in AA, it will say Dr. Tarakanath, gastroenterologist from Nellore. It hallucinates and gives all kind of data, talks all about neurology and cell at the bottom. Thanks for Dr. Tarakanath, gastroenterologist, for providing. So the hallucinations, and second is the black box issue, which you must have seen, that the gross black box failure which has happened in the aircraft, which has resulted in disaster of losing lives. So AA has got its own negative things also. So just a couple of illustrations on, I got 2 minutes left. So SCORE AA is one of the standardized computer. The second field which is really gone in is epilepsy. The standardized computer-based organized reporting of EEG, which is a European Union Act. This is the standard format of reporting. SCORE AA is the organized reporting of the EEGs. The SPARSNet, this, it identifies, it classifies what kind of epileptic discharges and group them. The grouping has done, and then it's produced a starfish pattern based on whether the generalized periodic discharges or whether lateralized periodic discharges or the rhythmic delta octave, everything is taken into account. All kinds of EEG patterns are taken and it is produced, and that's where, so you will know the moment you feed the EEG. See, for example, continuous EEG 24 hours in an ICU setup runs to pages, which I don't think you have time to, even we don't have time to see a patient for 5-10 minutes. So the entire data you have to depend upon AI. So in future, giving all these things. Not only that, very, very important thing is there are few things which you will never see. When you do a data mining, for example, hyponatremia, what are the changes which is produced in a continuous EEG monitoring. So you will never know that the associations which it can produce. There's going to be lot of areas of lot of research. I was so surprised, one of the very beautiful paper thesis which done by one of the resident from Amrita. I saw he has taken away multi-parametric monitors, data of 100 ICU patients and come out with earliest prediction of sepsis based on certain parameters, guided by Professor Anand Kumar. Amazing. He will tell you that kind of data, which taking into account and then putting on a deep learning algorithm and getting that. So this is the coloring map. I'll close my talk with these videos. You see, this is the kinematics one. You can see the kinematics, 3D screening, takes in the mapping and corrective exercise. You can see. Then second is speech. This is quite interesting. You'll see how. I'm sorry, it's not playing. This video is the last video, I thought. Let's play this video. What is done, it has. Place that video, yeah. Whatever is cognitive process and it is identified, you can definitely answer those questions. It's been now translated and the AI is able to answer. I'm sorry that audio is not, they've not connected the audio. It's fairly fascinating. It has helped in speech. The last one, my predecessor talked about the various exoskeletons. The era of exoskeletons, we have crossed that after the huge money which is spent on by Elon Musk on Neuralink, where the biodigital interface, where the biosignals of the signals of the biological signals are transformed into digital signals and bypassing the spinal cord injury to the segment below where it is intact, and then it has become successful, and that is the last slide. I wish that plays here. He's the first man, Nolan Arbug, who had a successful neural implant. He's able to play chess with a spinal cord injury, a transaction cervical level, where he's able to play chess. Now it has moved, just moving a cursor. It's not a big giant leap, but still, it's a move in the right direction. He's able to play chess with the Neuralink, the first patient of the Neuralink, where brain-computer interface. And another surprising thing, the substitution device, sensory substitution devices, where they output from an optic nerve. During a surgery, they want a biodigital interface. They were not able to find the chiasm beyond the lesion, so they fed it to the spiral ganglion, the auditory ganglion, but it home to the occipital surface by the network. So then only they realized that all these cables, the cranial nerves, are not modality dependent. They are task dependent. You can give the sensory, even visual supply to the tactile also. It will home to the occipital cortex. Then that has opened up a huge era of sensory substitution devices, and that is going to be the future. Thank you for your attention. I'm sorry for taking 30 seconds. Thank you.
Thank you, sir. We request you to continue on the dais as a panelist for the next session.
Sure, ma'am. Sure.
I would like to call on stage Dr. Deepthi to moderate the session Movement Disorders and to deliver her presentation on